from Shield Healthcare Medical Affairs.
Hi.
I'll start. Thank you.
We are live now, Monica.
Good morning, all. Good morning, all delegates, and welcome back to the Society for Maternal Fetal Medicine. And welcome back to the virtual learning series on preeclampsia. And I welcome our moderator, Dr. Anu Joseph, ma'am. She's an MBBS DNB OBG fellowship in MFM, and current designation, she's working in Trinity Healthcare Clinic as consultant and medical director, obstetrics and gynecology fetal medicine consultant in Kaveri Hospital in Bangalore, fetal medicine. Her area of interest are first trimester aneuploidy screening and prevention in high-risk pregnancy. She's an EC member, MAFM, and event coordinator, VLS PE. I welcome, ma'am, and I hand over the session to you.
Thank you. Thank you so much, Dr. Monica. Hello all, welcome you to the 6th and as of now the ultimate series on the virtual learning series with preeclampsia. We have been running through this year 2022 to 23 with a list of virtual learning series in which we have gone from beginning with what is preeclampsia, how do we define it, how do we diagnose it, what are the complications, how do we manage it. So the journey has now come to a point where we are in the last chapter of the book of preeclampsia, wherein we are now going to talk about what are the newer advances in terms of the treatment, newer advances in terms of management, and also to listen about how we are managing preeclampsia at the base root or the grassroots level from few of our doctors in the panel. So today, without much ado, I would like to welcome Prakash Mehta, sir. Sir is our light in guiding us towards lots of things, and especially our recognition of preeclampsia as a problem and something that we should talk about, we should instill in our juniors and our colleagues and in our seniors and the world over probably, to say that yes, preeclampsia is a killer and we need to know more about it so that mother and child can always be saved from it. Sir is a chief in the division of maternal fetal medicine at Mahavir Jain Hospital. Sir is also the president of the Society of Maternal Fetal Medicine India. Sir is a co-chair, the Indian co-chair for the Preeclampsia Education of the Nation India, which is a program that runs the VLS series, and is also the organizing president for the iShip World Congress, which is in Bangalore in September 2023. Sir has been awarded with Best Teacher Awards and Lifetime Achievement Award from the BSOG. He has worked immensely with lots of institutions of OG, be it the Bangalore Society of Obstetrics and Gynecology or the Indian and the International OG societies. Welcome to you, sir. Sir, sir, please do the honors of giving the welcome address and starting off the program for today.
Yeah, good morning, everyone, and welcome to the 6th program of VLSPE. It has been our aim to make sure that the latest in research reaches everyone all over India and outside India also. And today's program is a part of series of that particular series. At this time, I also welcome you all to join us for the World Congress of the International Society for Study of Hypertension in September 24 to 27 at Bengaluru. Please be there, and not just being there, but please present paper, because presenting paper in this prestigious conference will work wonders on your biodata. So don't be just present there, but also present the paper in this particular Congress, and it'll be of great help for your future development. With this, Dr. Anu, I think we can go ahead and start the program.
Chitrakala, can you please put up the remaining participants? Yeah. I would like now to introduce to you the delegates, the participants of today's discussion, and the panelist for today's panel session, which will follow through. First and the foremost, Dr. Revati. Dr. Revati is the secretary of SFMI and also is the organizing secretary for the iShip World Congress. She's also the Indian co-chair for PENAI, the Preeclampsia Education of the Nation. She works as the chief consultant of maternal fetal medicine and also the managing director at Mirror Health Clinic, and also works as visiting consultant for Milan Hospital, the Mahavir Jain Hospital, and also for other hospitals in Bangalore. Dr. Revati has immense interest in hypertensive disorders in pregnancy, in particular with preeclampsia and in utero fetal programming. She has won lots of awards, especially the UA Foxy Awards for the Young Orator and a Certificate of Excellence for the categories of research and young scientist. Welcome, Dr. Revati. The next slide, please. We'll go ahead with the introduction of our panelist also. Dr. Suma. Dr. Suma is a professor and unit chief of Department of OBG, JSS Medical College and Hospital, Mysuru. Dr. Suma has been a participant in organizing our Mysuru campaign of PENAI. She has done her undergraduate and postgraduate education from JSS Medical College itself, and she has done her legal training from Symbiosis University, Pune. She's a member of the governing body of the college, JSS Medical College, and also is the academic council member. She is an active member of Mysore OBG Society, and her interest is in high-risk obstetrics.
Thank you.
Welcome to you, ma'am. Dr. Shruti, she is one of the initial and the core members of SFMI, works at she has done her fellowship in maternal fetal medicine in BACC through RGHS, and has done her fellowship in advanced obstetric and gynec ultrasounds from Mediscans Chennai. At present, she is working as fetal medicine consultant at various hospitals in Bangalore. Welcome to Dr. Shruti. Dr. Saraswati, Madam requires not much of an introduction from me. Most of us know her through her academics, and she's a avid teacher. She's a professor, Department of OBG at Guwahati Medical College. She is been the chairperson of Medical Education Committee from 2013 to 2015. She was the vice president of ISOPUB 2020 to 2022, and chairperson and past president of the Guwahati OBG Society. She's the immediate past president of ISOPUB Assam chapter and has been a member of the editorial board of the New Indian Journal of OB-GYN. Welcome to you, ma'am.
Thank you.
Dr. Gayatri, she is our stronghold from Trichy, very interested in preeclampsia work. Her area of interest is high risk of obstetrics, infertility, and medical law. She is a consultant at Shamla Nursing Home, Trichy, an avid reader and an avid participant with us for our preeclampsia programs. Welcome to you, Dr. Gayatri.
Thank you, Dr. Anu Joseph.
With that introduction, I would invite Dr. Revati Rajan again to deliver her talk on the newer therapeutics, statins, the roles of statins and sildenafil in preeclampsia.
Thank you so much, Anu. I'm going to share my slide. Yes, good morning all. And today's topic is about novel therapeutics And definitely I would not be
Can
able
you
to.
make it screen share, Revati? It's not.
Sir, what will happen is sometimes the screen show gets stuck, sir. The
Okay.
slide doesn't move. So that's the reason. If you want, I can do it, sir.
Okay, no problem. Go ahead.
No
go ahead.
problem. Okay, sir, fine. So today what we're trying to deal with is about novel therapeutics. So we are not only talking about antihypertensives anymore. So can we do anything to improve, trying to modify the root cause of preeclampsia is our talk today. I'm not going to be talking about all the novel therapeutics. I'm considering statins and sildenafil in my talk. All right. So preeclampsia requires no introduction. It's a serious form of hypertensive disorder in pregnancy associated with severe maternal and perinatal adverse effects, and it complicates. I should say this is a very small number, and I'm sure Dr. Saswati will say, yes, it's more than 3 to 8%. It's something like 15 to 20% in our country, and it's not reported. It's the third major cause for maternal mortality in India. And we say this every 6 weeks on a Sunday to remind us that, yes, there's so much that we have to do through the VLSPE series. The maternal complications could be gross. I don't really have to remind this crowd because they are already passionate about learning about preeclampsia. It could be eclampsia, it could be intracranial bleeding, it could be coagulopathy. The fetal complications could be fetal growth restriction, prematurity, and stillborn. So what is very, very important to understand is it's more of an abnormal placentation which has been attributed to it, angiogenic factor imbalance, more so with anti-angiogenesis taking the precedence has been attributed to the root cause of preeclampsia. And we all know that preeclampsia represents a failed maternal stress test and may be implicated in future cardiovascular disease. That is something that we have to remind ourselves because we don't want these women to fall sick after delivery and end up having a cardiovascular problem. So the concerns, are we just going to be doing consequence management? Are we going to just identify high BPs and treat blood pressures and still, allow all the complications to follow and maybe have this lady have the cardiovascular problem later? Or are we going to address the root cause with some of these novel therapeutics? That's the essence of my talk. Now, let us start because it's a capsule. We just have about 10 minutes. Let me start with statins. Now, statins, we know that it has been long used for, it's a lipid lowering agent. And what it does is it actually works on the HMJ-CoA reductase enzyme, which is important for the conversion of the HMJ-CoA to mevalonate in the mevalonic acid pathway of the cholesterol biosynthesis. So what this does is this statin will inhibit this enzyme. So we do not have this mevalonic acid being formed. So when this does not happen, it's a competitive inhibition. And it's a rate limiting step. So we have decreased downstream production of cholesterol, and that can be responsible for lowering LDL. And this is the property that we've been using in people with cardiovascular disease to lower their cholesterols, because LDL is the primary cholesterol which causes cardiovascular adverse effects. Now, just to give you an information, because I can't tell you everything about statins, we have first generation statins, we have second generation statins, we have third generation statins as and when they evolved. And the most commonest of the popular first generation is the pravastatin, but it is least potent. Second generation is atorvastatin, widely used. Third generation is the rosuvastatin, which has the highest potency. And this has been based on how their use has been in modifying cardiovascular disease. Now, you have to understand a little bit about the pharmacokinetics. We can also categorize them as lipophilic and hydrophilic, but going into the details of it is not part of this discussion. But what you have to understand is they are all metabolized in the liver. Statins are absorbed rapidly following oral administration. They are also bound to plasma proteins. And whether they are hepatoselective or not, they go through the liver. This is something that you have to understand. The general contraindications, hypersensitivity to the medication. Pregnancy, FDA categorized it as X. I'm going to tell you it is no more holding good. There have been some relative indications where you can use statins. Lactation, yes, still not allowed. Acute liver failure. So it's got very less number of contraindications compared to so many other drugs. The interactions, yes, There are some cardiovascular drugs like amiodarone, which has been used as an antiarrhythmic drug, used with other statins. Cyclosporin, these are all immunomodulators, colchicines and antiretroviral therapy. I'm telling you all this because you could have a HIV positive patient who would be preeclamptic. You could have a lady with a renal transplant who could be preeclamptic. So you could have a lady with a arrhythmia who's preeclamptic. So we need to be really aware of all this as maternal fetal medicine specialists. What is the role in PE? We are only talking about cardiovascular disease. Statins upregulate the eNOS, which promotes the nitric oxide production in the vasculature. It promotes more of angiogenesis. So vascular endothelial growth factor is high, PLGF is high, SPRIT1 comes down. And most importantly, it has a lot of anti-inflammatory properties, which we actually call it as pleiotropic. It also brings down inflammation. So Th2 anti-inflammatory cytokine production is high and Th1 is suppressed. Now, this is the same diagram. I wanted to show you this very interesting diagram, and this has probably come out in 2020. It's a little difficult. This is a screenshot from the article, but what you have to understand is if the preeclampsia, if the pathophysiology is about inflammation and endothelial dysfunction, statins can help reduce inflammation and oxidative stress and stabilize the endothelium by promoting angiogenesis. This is how it works at the molecular level. It can work at the placental trophoblast cells. It can work with the platelets, the monocytes, to reduce the inflammation. And what you have to understand is we are not using statins because they reduce the cholesterol. We want statins because of their pleiotropic effects, and this is more of reducing inflammation and oxidative stress and promoting angiogenesis for preeclampsia. This is something that I want to impress the audience. Now, I don't have any other method by which I can probably tell you about statins because it's only about studies. I have not been using statins, but I'm really tempted to use them. But yes, we have a long way to go. Now, what are the summary of major studies, with the other thing that concerns an obstetrician gynecologist is about the fetus. What about the congenital anomalies? It's blocking the cholesterol synthesis. I'm also going to tell you what was actually thought of as a major concern with statins. Most of the studies have been done with pravastatin, though it is least potent because people are really scared to be using higher potency statins in pregnant women. And the dose has usually been about 20 milligrams twice daily. And most of the studies, which are kind of properly structured with less numbers, have shown no direct congenital anomaly, which has been associated only because of administration of pravastatin, which is reassuring. Most of these studies have been done after 14 weeks. Nobody has dared to do or give pravastatin in the first trimester. So in human studies, there have been two kinds. One is people have started using it earlier. People used to give it to people with established preeclampsia. But yes, it did help, maybe give them a week or so because the angiogenesis bettered and the anti-angiogenesis came down a little bit. So the profiles improved, the blood pressures kind of stabilized. Maybe a 26-weeker got a 28-week, kind of a gestation, and that kind of helped. But it didn't do anything very significant, just like what it does in a cardiovascular disease profile, where it can probably modulate or change the outcomes completely. And that was mainly because maybe these statins had to be used a little earlier, not at around 26 to 28 weeks when the root cause has already, become florid. You should have probably used it at 14 to 16 weeks to stabilize the endothelial dysfunction so that you don't have much of SPRIT1 release. And so you can actually promote angiogenesis. So this thought has come in the mind. It's not for treatment, it's for prevention. But what was the concern? The FDA was always talking about Smith-Lemli-Opitz syndrome, which is because of cholesterol, where there is an inhibition of cholesterol biosynthesis, primarily because statins were looking at the most important rate-limiting enzyme of the mevalonate pathway. And if a baby develops, because most of these enzymes are very important for the structural development of the baby, both metabolically as well as structurally. So the Smith-Lemli-Opitz syndrome is manifested by derangements in growth, microcephaly, mental retardation, multiple congenital anomalies, abnormal facial features, cleft palate, heart defects, fused digits, polydactyly, underdeveloped external genitalia, and so on and so forth. But let me tell you, this was like an all or none. I mean, they did not specify whether it happened in the first trimester, what was the dose, which was the statin, did it happen in all fetuses? And so people started exploring, and there have been several European humans studies, some of them in North America, but they have used pravastatin starting from 14 weeks, and they did not really find this outcome, but the numbers have been very, very small. And what was very, very interesting was, when they controlled it, when they used it with a placebo, the preterm deliveries came down because of pravastatin use, maybe because the blood pressure stabilized. This was already after established preeclampsia, but what was concerning was the NICU admissions increased, but nothing to do with congenital anomalies. Now, what is very, very important is there is a big meta-analysis, but meta-analysis is collecting the number of studies, but the number of recruits in each study was small because of its, statins was not, we can't use, we can't do bigger studies with great numbers with statins right away because it requires a lot of counseling and ethics committee approval and so on and so forth. So in 2021 has clearly said statin use does not increase birth defects, and most of these studies have been in this use in the second and the third trimester. But what is very, very, very important is, yes, I mean, if it is not really doing anything in the second and third trimester, then there is this cohort which is saying, then why can't we use it to stabilize the endothelial dysfunction that is happening in the second and third trimester? Why can't we use it along with aspirin? So finally, there was another study where they used aspirin with statins in the second trimester, just like how we use aspirin in screen-positive people. But they found that there was no great effect because statin was added. So they don't know whether aspirin was doing the job or people were not taking aspirin because of non-compliance issues. They took only statin. So there were so many problems with that study. But yes, statins started at 14 to 16 weeks, did really well with the angiogenic profile. So this is something that we have to take it very seriously. If we are looking at ART conceptions, if we are looking at elderly women who are conceiving with a lot of predisposition to preeclampsia, can we make a difference by giving them at 14 to 16 weeks? And let me tell you, the studies have always been on pravastatin, and most of the times pravastatin has not, these are all studies that happened after 2016, and there have been systematic reviews, there have been meta-analysis, and they have not really found anything which was significant associated with pravastatin with respect to congenital anomalies. And yes, it has done a lot of good because sometimes, fetal growth restriction has benefited. That is because there has been an effective increase in weight gain. The blood pressures have stabilized. The viability in terms of gestational age prolongation has increased. The Dopplers have bettered because of better angiogenesis. So these kinds of benefits have occurred with pravastatin used at a dose of 20 milligrams BD in starting from around 14 to 16 weeks. So with all this, there was this question. I mean, FDA said it was category X, so you can't use it on anybody. But yes, now it has kind of been a little liberal. And when you look at women with familial hypercholesterolemia, these women have a very significantly high risk of preeclampsia. And they have allowed to use statins for risk modulation. They can be continued in these women because they are really going to have bad preeclampsia. And yes, that is reassuring, but yes, we need to really work it on to get a standardized recommendation for all. And let me tell you, we are not using potent statins at very high doses to suppress cholesterol synthesis like we use in cardiovascular disease. We are using statins only for their pleiotropic effects. And so we are using the least potent one in the least possible dose, starting it a little early. This is something that we really have to work on. Yes, postpartum, it has reversed the cardiovascular dysfunction. It has actually looked at something called the downregulation of ROC1, and this is on animal studies. So if you have administered statins in these rats, antenatally, these rats did not have postpartum cardiovascular dysfunction. Can we use it in our women? We've been using this for cardiovascular reasons. We use it because statins can prevent platelet activation. It can prevent thrombotic effects. It can cause plaque instability, and these kinds of, it can, suppress the formation of plaques for cardiovascular reasons. So can we use it in these women during pregnancy? continue it, avoid the progression to future cardiovascular disease is something that we really have to deliberate now. So this is about statins. I'm going to summarize. We have about 4 or 5 slides of sildenafil, and then maybe we can take a summary of that. Now, moving ahead, there is this new drug, which is again sildenafil. This is more, tapped for fetal growth restriction, which could be a consequence of endothelial dysfunction, which could be again a manifestation of preeclampsia. What it does is it inhibits the phosphodiesterase type 5, PDES, an enzyme which is responsible for degradation of nitric oxide, and its efficacy is greater in the placental territory. So it is primarily looking at the placenta, and it prevents degradation of nitric oxide, allows a lot of nitric oxide, and that could have a vasodilatory effect and better perfusion. Now, the pharmacokinetics, it is again cleared by the liver. The half-life is about 3 to 4 hours. It's got a very short half-life, unlike the statins, which have about 10 to 12 hours, even the least potent one. So that's a BD dose. But sildenafil has been used as a TID dose. The sildenafil contraindications, obviously, allergy, nitrates. You can't use it with nitrates. I mean, you could find, a pregnant woman with a history of angina who's on nitrates, because nowadays we are having 40-year-olds coming to preconception counseling, and they would have been survivors of an MI. So as a maternal fetal medicine person, I have to take a detailed history. There could be problems like liver diseases, sickle cell anemia, hemophilia, and multiple myeloma are contraindications for sildenafil, and history of hypertension. See, we have seen a lot of these generalists say when a lady is hypertensive, we should not give sildenafil. That's not true. When she has hypotension is where you should not give sildenafil. It can be used with other antihypertensives, but with judiciously. You should know the pharmacokinetics of that drug. Now, what it does is we've seen that because it improves the amount of nitric oxide, it probably increases the fetal weight at birth in placental insufficiency, despite the limitations of several meta-analysis. There has been an increase in some, we see a lot of these patients who are severely fetal growth restricted. They're somewhere at 24 weeks, their weights are at around 300 grams. So if you get another 200 grams and you, with the use of sildenafil, and reach a gestation of 27 weeks, obviously this baby will do much better, and economically it's also good for the patients. Yes, so there have been several studies. This is a study which was in 2017. This was on animal models, and that again told us that yes, it can improve fetal growth and maternal blood pressure regulation. So it can also kind of stabilize the blood pressure. And what is very, very important is we have an Indian study which was also published. And this study was in 2019. This was a combined, this is more of a European study as well as an collaborative study, where they found that there was an increase of 222.58 grams after administration of sildenafil. Most of the times it's a 25 milligram oral dose. The vaginal doses have only been used by the ERT people to increase the local perfusion. And what they found is, additionally, yes, the addition of sildenafil citrate to low dose, but what they found was you can't use it for prevention. You can't use it along with aspirin and say this lady will not develop preeclampsia. What you can probably do is, in a lady who is having fetal growth restriction or the effects of preeclampsia, you can maybe postpone complications and reach viability, is what most of them have told. This is an Indian study which came out in 2021, and they were particularly looking at increase in fetal ACs and fetal weights and pregnancy duration, which is very, very important in our country. I would definitely want to, get that kind of a good gestation and a good weight for this fetus and reduce the cost, from the NICUs.
Dr. Evti? Hello, Dr.
I think we have lost you.
Calcium. Hello, sir. Can you hear me?
Yeah. Now you're fine. Now you're fine.
Yes, sir. Yes, sir. So alterations in the intracellular calcium, it can cause it can cause, it can affect the DNA synthesis. It can also cause, it enhances nitric oxide, but a lot of nitric oxide can be derogatory for embryogenesis during the organogenesis period. So this is very important because your ART specialist will put sildenafil post-transfer. Please tell them this can cause embryo toxicity. You can't use it after transfer. So first trimester, post-implantation, you can't use sildenafil. You can only use sildenafil as a therapeutic drug. It can't be used for prevention of endothelial dysfunction. So the key points, remember, we are using statins not because it can lower cholesterol. So we are not really looking at congenital anomalies. We are looking at pleiotropic effect, which is anti-inflammatory and immunomodulatory effect. It is no more FDA categories X, which is reassuring. It can be used or continued in women with familial hypercholesterolemia. Use of statins is not an indication for termination. I have myself continued a lady with statins and nothing actually happened. But yes, you have to continue surveillance. Pravastatin, most commonly used. We are not looking at potency. We are only looking at pleiotropic effect. But yes, we need really big studies, well-structured studies from all over the world to say that it can do good. Not after preeclampsia has set in, maybe at around 14 to 16 weeks, where you can modify the disease. With respect to sildenafil, it's been mostly on FGR. It's not for prevention of preeclampsia. It can never be used in the first trimester. Don't use it post-transfer, post-embryo transfer. It is contraindicated in the first trimester. And if you're looking at a country like India, maybe it has a role to increase the fetal weight and prolong gestation so that the babies can be better managed in the NICU. There are a lot of other discussions as what it can do, what the baby can have after sildenafil is stopped, but it is beyond the scope of this talk after the baby is born. So thanks a lot for our patient hearing. And I would also want to tell you, if you want to listen to more and what is happening to the novel therapeutics in great detail, we have this talk by none other than Dr. Anant Karumanchi, who is one of the pioneer researchers in the world, who is doing a lot of work on the biomarkers and novel therapeutics. Please come to the iShip World Congress and listen to this talk, and I'm sure it's going to be very enlightening. Thank you so much.
Thank you so much, Dr. Revati, for that presentation. It was new, definitely, and very informative. Thank you so much. Without much ado, we'll go on to the next program. I re-invite Dr. Prakash Mehta, sir, to moderate the panel discussion on novel strategies for combating preeclampsia in India. I welcome the panelists, Dr. Saswati, Dr. Suma, Dr. Shruti, and Dr. Gayatri.
Yeah, good morning again. Revati, if you can stop sharing, I would be able to share that.
Stop, sir. Stop. You can share, sir.
Okay, so now today we'll have a discussion on what are the novel strategies. Do we have any more new knowledge about preeclampsia with maybe etiology, maybe management, it may be investigation? Do we have any novel strategies? And to discuss this particular topic, I have a good mix of senior and the younger people. Senior people for their experience, younger people so that we have a more of a, kind of a pushy, newer things coming in. So I have Dr. Shashwati Sanyal from Guwahati, Dr. Suma from Mysuru, Dr. Gayatri from Trichy, and Dr. Shruti from Bengaluru. We know that preeclampsia is one of the leading causes of maternal and perinatal morbidity. It's an elusive condition to diagnose and a complex disease to manage. Inflammation and placental dysfunction and imbalance of angiogenic factors, of course, play a crucial role. Women in low and middle income countries carry most of this burden. So it becomes very significant that we in India manage this condition very, very well. A significant barrier to reducing the global burden of preeclampsia is what we call the drug drought. We don't have good drugs to treat. We've heard a lot about statins, but at the end of it, we still do not know. It's still considered an experimental drug. Still, we need more research on it. So we have a drug drought and a lack of medicines for this pregnancy-specific condition. So when we talk of novel strategies, we'll go into prevention and prediction, we'll go into management, and we'll go into education and training. See, there's no point in only us learning a lot about the novel strategies. We should take it down to the community. Unless we take it down to the community, we are not going to achieve our goal. Now, coming to the newer developments in prediction and prevention. Now, we know preeclampsia is notoriously difficult to predict. Accurate prediction model we have, then targeted prophylaxis with aspirin as well as enhanced surveillance. We may be able to mitigate the adverse outcomes, but we still don't have what we call as an accurate prediction model. Now, with this, to try to identify the etiologies, we'll go to the first question. Do infective factors play a role? Is there a role for urinary tract infection or Helicobacter pylori to cause this condition? And to answer this, first panelist would be Dr. Gayatri.
Thank you very much, sir. Doubtless, I'd like to thank Dr. Revati Rajan and Dr. Preekash Mehta for making me a part of this wonderful movement. For every doctor who is practicing good amount of obstetrics, we can't do without this. And the more we study about it, the more we know how much how much is left to be uncovered. I think for a long time, we've always been looking at preeclampsia as a placental disease, a triad of insufficient placentation with the placental dysfunction and the forthcoming vascular reactivity. And this cascade has been always known to, be the cause of preeclampsia and so far. But I think the recent evidences and a lot of papers have been published as to why can't it be different, like especially these things where the asymptomatic UTI or a subclinical and a long-standing infection like Helicobacter pylori. We had a few studies being published where they said that early detection of this asymptomatic urinary tract infection and treating them before maybe 20 weeks of pregnancy and following up the pregnancy, there were enough evidence to say that this reduced the incidence of preeclampsia. The proposed mechanism has been the decrease in the inflammatory cascade, which is attributed to the asymptomatic UTI. Any acute and a big infection, they attract enough attention and we treat it and we are able to get away with it. But what happens in this asymptomatic infections, the chronic low dose inflammatory mediators and cytokines that keep invading the maternal system could in fact be the reason for preeclampsia like cascade. So now, in fact, we are not sure whether the cardiovascular system and other target organs are the victim of preeclampsia or the culprits themselves. So now the a lot of latest researches are going into the stream, and we have a lot of papers published saying that similarly this H. pylori, not just preeclampsia, in a lot of field of medicine, H. pylori infection is gaining a lot of importance because this is a subacute infection. We do not have specific symptoms and it is very difficult to find out the presence of them. And such ones are the ones which chronically, keep releasing the inflammatory mediators, leading to such problems.
Yeah, thank you, Gayatri. I think you brought it out very well. Now, we know that preeclampsia is ultimately dysregulation. And in dysregulation, we have the anti-angiogenic response, we have the abnormal trophoblast invasion, we have the altered immune response, and we have the oxygen disruption. And it has been found that the microbes could affect any of these pathological routes. So that is why microbes are very, very important. And see, most of the microbes are dormant. They do not have a clinical disease. They're just present in the paper, and hence there is this detection by the conventional microbiology. So if you do a routine culture, you're not going to pick it up because they're in a dormant state. But a resuscitation of this organism and growth becomes responsible for chronic inflammation. And you know that the lipopolysaccharides, or the so-called endotoxin was the old word we were using. Now we use the word lipopolysaccharides, are highly inflammogenic and stimulate an innate immune response that will exacerbate the inflammation further. I think Dr. Gayatri brought this out very well. And it is also known that the infectious component of preeclampsia fulfills what we call as a Bradford Hill criteria. Bradford Hill criteria is the criteria to identify if any disease is infective in nature. And preeclampsia fits into this kind of a definition. And if you remember the olden days, we would call it as toxemia of pregnancy. Initially, preeclampsia was called as toxemia of pregnancy. And now it has become ironic that it seems that the lipopolysaccharides and other microbial endotoxins are involved. So we are going back to the definition of toxemia. Okay, the recognition of infectious component in etiology of preeclampsia mirrors that for ulcers and other diseases. If you remember, when any of the seniors here would remember that when we were postgraduates or even undergraduates, the treatment for peptic ulcer was GJ vagotomy. And most of our OTs were filled with GJ vagotomies all the time. We never thought that a bacteria could be a cause for peptic ulcer. So the question that arises now is, are we in the same mode for preeclampsia? Would 5 years later somebody would laugh at us and say that probably we could have given simple antibiotic and cured preeclampsia rather than going through so much of adverse effects? Okay, now basically the whole infection acts through iron dysregulation, leading on ultimately to inflammation and inflammatory cytokines. Okay, that's the same thing given in the form of a slide about the P biomarkers and infection, how the biomarkers could change, how a proteinuria could come in preeclampsia, all because of LPS, that is the lipopolysaccharides or the endotoxin from the bacteria. Now coming to the H. pylori, is the most popular pathogen worldwide. Nearly half the population of the world carries H. pylori in their system. And it is associated with diverse gastric diseases, including gastric ulcers, progressive gastritis, or even gastric cancer. Now we know that it is related to many numerous extragastric diseases. And H. pylori doubles the risk of developing preeclampsia. That has been proved. That if you have H. pylori, you have double the chance of getting preeclampsia. And a special strain called as the CAG-A positive strain, which gives a higher level of inflammatory mediators leading to preeclampsia. So would we be soon treating preeclampsia with antibiotics? We'll have to wait and see. So with this, we go to our question.
Can I add one thing,
Yes,
Dr. Prakash?
Please,
Yeah.
please.
I have done a study on dental caries and the risks of bad obstetrical history, including preeclampsia. And we have found there is a very strong relationship between the dental caries, chronic periodontitis, and the outcome of preeclampsia. So that absolutely explains the way you have explained how the infection plays a role.
Correct. Absolutely. We need to do a lot more work on it. Today's panel was just to make sure that the youngsters who are attending this meeting at least get stimulated to do some kind of a research or some kind of a study on whether all these are useful, are they applicable in our situation, would it make any difference if we treat them?
I think, sir, the booking, when we try to screen the patients from head to toe, as we always say that we are the screening people for the normal population. A normal woman who's never been to a doctor before comes to the obstetrician first time when she sees her urine test positive. So I think we have more of a responsibility. Absolutely. Where we properly screen her from head to toe for any of the asymptomatic, like madam said, even a dental carie or anything. And maybe this is the way forward to better prevention of it. Yes, it's multifactorial. We may not come to zero, but yes, it could be really a great way forward.
Absolutely. Now with this, we go to the next question. We know that preeclampsia, with prediction of preeclampsia, we've discussed this in the previous VLSPE many times. But coming to the prediction of recurrent preeclampsia, I've had a patient with preeclampsia last time. How do I predict whether she's going to get preeclampsia again or not? Question goes to Dr. Shashwati Sanyal.
Okay, thank you, Dr. Prakash, for involving me in this particular interesting session. Now, early identification of at-risk women is really a challenging one. Now, all the identification at risk is mostly done in the first or second trimester. We have a very few prior to the pregnancy. We have very few models, that is prediction model for risk stratifications. And we have seen that around 15% or sometimes even 60%, 55%, they have a chance of recurrent preeclampsia. It depends on the multiple factors. Say, for example, at what gestation this time the preeclampsia has occurred, the severity of the disease, then if there is associated pre-existing medical disorder, especially the diabetes and hypertension, then we do not have a single biomarkers like everything what we do for normal prediction for preeclampsia, like BMI, which has got a specificity of 92%. We have uterine artery PI. If it is more than 90th centile, it has a specificity of 93%. Only PLGF has a specificity of 89%. And if it is PP13, the specificity is 88%. Now, if there is a adverse outcome like preterm delivery, fetal growth restriction, intrauterine fetal death, and abruptio, then there is increased risk of adverse outcome. In 2022 June, there was a prediction model for risk stratification that is in pre-pregnant state, and they have taken around 1,028 patients. And the factors they found was if there is a patient has history of migraine, if there is a first degree relative have cardiovascular disease and placenta-related complication, then the gestational age at delivery last time, weight of the fetus, abruptio, then chronic hypertension, pregnancy interval between the two pregnancies, and of course, the age. And the recurrence rate has been seen. If it is a simple preeclampsia, it can vary from 16 to 65%. Different people has given different. If the patient has a complication like HELP syndrome, it can go up to 25%. And if it is a preterm delivery, it can go to 55%. But the early onset preeclampsia has a highest chance, that is around 65%. But if it is only a gestational hypertension, it will be around 2 to 3%.
Yeah, thank you, Dr. Saraswati. It means that whenever you get a patient who has had a previous preeclampsia, you need to go into a history in great detail, make sure that you individualize her and give her a proper prevention strategy. Quite often I get asked the question that why should we do all this? Anyway, ultimately, if there is a risk factor, I'm going to give aspirin. Remember, aspirin is not a magic bullet. Aspirin is very good for preventing preeclampsia, but it is not a 100% effective drug. Even if your patient gets aspirin, she may still get preeclampsia. So you just can't say, just because I'm giving preeclampsia, I'm not going to go into the details of the patient. We need to really work up these patients, because a chance of 25% is too great to miss this patient. Now, the next question goes to, now we are moving into a very, very modern era. So, Dr. Shruti, what are the newer vistas in Doppler prediction? Is there a role for ophthalmic Doppler?
Yes, sorry for my voice. There is a newer thing of the ophthalmic Doppler. It is used both for screening for preeclampsia in the first and the second trimester. And in the third trimester, it's a window into what are the cerebrovascular events that occur in the brain of a preeclamptic woman. So instead of subjecting the woman to CT and MRI, we could use this ophthalmic artery Doppler in the third trimester in a preeclamptic woman to see what are the cerebrovascular changes that has happened in her. Like for breast, we have to go into MRI CT. So before itself, we can predict if there is going to be any neurological deficits. And for screening, now it is being used. It's a very simple OPD procedure where a linear transducer is placed on the eyeball, and the ophthalmic artery, the Doppler gate is placed on the ophthalmic artery, and a waveform is taken. So mainly the peak systolic velocity, the PI and the RI is calculated. So if the resistance index is more, then it could be a predictor for preeclampsia.
Yes, absolutely. So it's a very simple test, but we still are not sure as to how good it is for prediction. But that's why I told you before, only whatever we are discussing today are mainly meant for our postgraduates or the younger OBGYNs who are attending this program, so that they can start thinking about it and working on it.
Yes, we also started doing this because we are planning of doing a study on this.
Shashwati will be the youngest person in this entire group because she's very, very pro-research.
Because it is a very simple procedure, just put it your that very, very simple, and it is reproducible. Whoever does, because our obstetricians in our medical college, they are very much used with the ultrasound. They do it ultrasound very right and left for all patients. And that is why it is a doable one. So let us see what it comes out as what.
Absolutely.
Excuse me, sir.
Yes, please.
Yes. Sir, even we are doing the same ophthalmic artery Doppler study for preeclamptic women in our department. And we have also found the same positive result. So the difference, there is a very good significant difference is there between the normotensive and hypertensive. And also with severe hypertension, the significance also still more. We are having positive results, sir, but we are not yet concluded the study, so it is still going on.
I know. We are going to get all our answers in the next couple of years as to would this test be a part of our routine care or not. Now, we already saw how pathological organisms were important for preeclampsia. Now, let's go to the physiological organisms. The gut microbiota are now becoming very, very important for all the diseases because we have been ignoring the normal bacteria that are present in our GI system. And between the gut microbiota and the preeclampsia, is there a connection, Dr. Gayatri?
Yes, sir. Actually, yeah, just like in the extension of what I already said, now we realize that there was a time when we used to treat most of the, diarrhea and acute gastroenteritis cases with antibiotics and other things. But now we know that the way forward is the prebiotic and probiotics. Once we started having results in that and we started extrapolating those results, we realized that the gut microbiota has a lot more things to do. They, secrete a lot of short chain fatty acid, long chain fatty acid, and all of them have complex mechanism in a lot of things happening within our body. And as such, this gut microbiota, the more and more people started having interest in it, we have a lot of papers emphasizing the importance of certain kinds of bacteria, which when available in good quantity in the gut microbiota, decreased incidence of preeclampsia in those women. And since now the lifestyle and everything is now changed, and we have a lot of abuse happening to our stomach, a lot of processed food, a lot of everything which alters the gut microbiota. I think this is this and a lot of other things, as and when the technology has been improving, vitamins like vitamin D, the gut microbiota, in all the diseases, these seem to be having a lot of role which has been underseen so long. So this is again another way forward to us. So by just replenishing very well and having a very nice nutritional counseling to them, how to replenish these gut microbiota, we can really decrease at least the preventable causes of them, where they do not have basic other problems.
Absolutely, because bacteria like Akkermansia, mucinophilia, and others which produce short chain fatty acids, alteration of them have known to result in preeclampsia. So possibly in future, if we start using a fecal pill for treating preeclampsia, it wouldn't be a surprise. So let us see if you're going to do fecal transplant for our patients in future. We'll have to wait and watch.
Maybe in case of recurrent preeclampsia, it could be a way forward if we can.
Absolutely. Okay. Is there a role for mesenchymal stem cells in pathogenesis and management, Dr. Shashwati Sanya?
Madam, you're muted.
Yeah, this is a new area where we have seen that mesenchymal stem cells. In fact, these mesenchymal stem cells are present in the decidua. And it has a low immunogenicity. It has a pro-angiogenic, anti-inflammatory, antioxidant property. And we all know that this is the mechanism by which the preeclampsia develops. And it also has an effect on the toll-like receptors. And if it causes the TLR3 stimulation, then there are immunosuppressive effects. Now, these MSC, they actually walk through some secretomes, which has a paracrine signals. And these paracrine signals, they produce this all low immunogenicity and progeogenic, etc. And this decidual leukocytes also promote migration of these invasive extravenous trophoblasts to the uterine artery, that is where you have the changes, the remodeling of the basal part of that uterine artery, spiral uterine artery, by they secrete chemokines. Now, the mesenchymal stem cells directly, they don't work. They actually send some extracellular vesicles, which plays a role in the exchange between the immune cell trophoblast for immunotolerance. And this MSC injection in mice, they have done an animal trial in a rat model where they have LPS-induced preeclampsia, and they have found that it can recover the TH1 and TH2 balance, and it also, interestingly, it ameliorates the spiral uterine artery remodeling, which is a very, very interesting finding. And because the MSC has got a lot of problem of developments and all these things, so they use nowadays extracellular vesicles, which is an alternative to this MSC. And in fact, these vesicles has all the required elements, especially they have the mitochondria, and their mitochondria, they transfer to the target cells, where they correct the mitochondrial dysfunction, which will thereby enhance angiogenesis and reduce infarction. So these are the different animal studies that are going on, and whether these studies, whether it is be applicable to the human beings or not, that is still under prediction. But initial workup has been very, very interesting.
Absolutely, because we know that the crosstalk between cells is very important in development, especially the crosstalk between the mesenchymal stem cells and the endothelium, the trophoblast, and the immune cells in placenta. If there is a high senescence or a high apoptosis in the mesenchymal stem cells in the uterus, possibly the incidence of preeclampsia is going to be much more higher. Injectable stem cells have been used for the treatment of preeclampsia, but then now we are going further refinement because we do not know whether these are safe in pregnancy or not. So only the exosome, the MSC-derived exosomes, are now being experimented upon, and again we'll get our answer in the next few years.
Because MSC also has a tumorigenic effect, so
Absolutely.
that to avoid that.
So finally, I managed to get Dr. Suma into the discussion now. Is there an effect of exercise and yoga on preeclampsia? Should we be advising this to our patient? Is it useful?
Yes, sir. Good morning to everybody. Thank you, sir, and team SFM for giving me this opportunity. Actually, there is an effective role of exercise and yoga even in prediction, in management, and even preventing the preeclampsia. That is what the study says. And prenatal yoga, actually, it is a modification of the classical yoga, which has been adopted, keeping in mind the physical condition of the pregnant women, wherein the exercises which they teach will be a little bit gentle compared to non-pregnant women, and it will be of slow intensity. And there is an extensive study by Dr. Raksani et al. Way back in the year 2012. And she has made the conclusive remarks that there is a positive effect of yoga for pregnant women in the form of decreasing the incidence of preeclampsia and FGR and even gestational diabetes mellitus. So what do they advise actually in yoga is they always advise stretching exercises. Here they have told that the stretching exercises are more effective than walking itself. And they also advise about postural modifications and involving some exercises in relation to posture. They do advise deep breathing exercises and meditation. All these things have been advised, keeping in mind just to unify the mind, body, and the spirit. And usually it is not an extensive, not that patient has to do it for hours together every day. Actually, it is advocated that the yoga exercises are advocated for about minimum 30 minutes in 2 weeks, actually, for 2 months. And we should also keep in mind that exercises always provides cardiovascular conditioning and decreases the BP. And also it decreases the oxidative stress, which is also a contributing factor for the onset of preeclampsia. And it is also known to stimulate the vascularity and also helps in placental growth, and also it prevents the dysfunction which is happening in the walls of the blood vessels. And even they have shown that the
Dr.
slow
Ma'am?
breath- Hello?
Sorry to interrupt you, ma'am. Ma'am, your video is being masked in between. We can't see you.
I don't know,
able to
but
see.
I have switched on the video.
No, ma'am. There's a paper flying near you.
I think
Paper,
it's a
some
fan
paper
or
flies
something.
in
Just a
between.
paper which is fluttering near you. Nothing else.
That's all.
And also what they have told is when the yoga has been advocated to a pregnant woman, the slow breathing and rhythmic breaths which is advocated for the pregnant women, that is also known to activate the central nervous system, and mainly it is also known to block the cortisol, which is also involved in the onset or initiation of the hypertension. So usually they advise Balasana, Paschimottanasana, and Virasana and Shavasana for all these things. So ultimately, the final result is there is effective therapy. Yoga and exercises have effective therapy in reducing the hypertension-related complications, both in the pregnant women, and also it is known to improve the fetal outcome.
Absolutely.
So it is always better to advise yoga, because as I told, it is only 30 minutes of yoga for only once in 2 weeks that need to be done for 2 months.
Okay, so we need to have some kind of a structured exercise, which should be a combination of aerobic, strength, and flexibility workouts or yoga for preventing the onset of hypertensive disorder of pregnancy. Yoga is a low impact physical activity, maybe more acceptable and safer for women in pregnancy. And we are from the land of yoga, and sometimes I wonder why we are not using it to the extent that we are supposed to be using it. In my hospital, some of the other departments have already introduced yoga. I tried doing it, but somehow, because my practice is mainly referral, the patient comes too late to me. It's not that they're coming to me from first trimester. So for those of you who have got this well-booked patients coming in for delivery all the time, please use yoga. It may be of great help in bringing down the incidence of all complications of pregnancy, not just preeclampsia.
And also, sir, even though the results are say that it has got positive effect, one thing, as I told earlier, there is a modification of yoga for pregnant women, keeping her physical condition. But still, few cases they have found out the disadvantage with pregnant women with distended abdomen, and also even though the yoga relieves backache, sometimes in few women it is also known to cause low backache. So that could be one of the disadvantage thing.
Absolutely.
Incidence is less compared to
because when we are ordering swimming for the patient, we tend to follow the Western culture more than what our own culture is. So we say, okay, you can do a swimming, you can do a sitting on the ball in your labor room and all that. Compared to that, I'm sure yoga would be much more harmless. And more important than yoga brings down the stress. And today we know, at least in the city of Bangalore,
Better oxygenation also, sir, because of pranayama.
Absolutely. And in Bangalore city, especially, we have patients who are all stressed out. Many of them are software engineers who are working for 8 hours, 10 hours, 12 hours a day, trying to meet their targets. And in the bargain, they have a terrible pregnancy. So this particular slide shows how the amount of stress came down over a period of 4 months. And I think if stress comes down, possibly our results are going to be much better. Okay. Next question to Dr. Gayatri. We are all become very fond of eating processed food. McDonald's and KFC have gone over into the smallest of the towns. We want the burgers and we want the pizzas. And quite a few of our patients say, oh, I love pizza. I can't stay without pizza. So do processed food increase preeclampsia?
I'll be really happy to take this question, sir. Literally all the nutrition part of it. Sir, actually, we have a lot of insights and thoughts that genetically each geographic area, we are used to some kind and pattern of food and we should respect it. Indians, we are made by the Indian genetics, and we probably, are much better off, and our tummy and our whole system works much better with a little higher carb and, a little of rice, wheat, and all these things compared to even the paleo and other diets were not too popular here because such high proteins were not very successfully handled by everyone in the Indian system. Similarly, when we go on, we are always but attracted to the westernization and Western pattern of everything. There are a lot of benefits, lot of advantages in being, going towards, westernization, but we should also keep our roots strong. Now, when we go too much towards the westernization of food, as the picture shows, these donuts and pizzas, the Italian, the Mexican, and all those things, we forget that our gut is not basically tuned to it. The microbiota, everything is not the one which can tolerate this day in and day out. Maybe once in a while when we abuse, we really don't get, harmed, or we don't get really injured. But if we are going to constantly abuse it with all these processed food, the variety of, the vinegars and all those preservatives they use and other things, all these things again, now they are going to go and damage the gut microbiota. And they are going to cause little small inflammation everywhere. The type of the small chain fatty acid and all the metabolic outcomes which are not very much used to us. All these things are going to little by little add on to small inflammation, going in for a chronic inflammatory state, again increasing the cytokines which are now going to be damaging to us. For a normal person, fine. But when you are going to be pregnant or in the preconceptional phase or in the first trimester, this could really be damaging to us. We have enough data on that. And all these things are interrelated. How the processed food damage our gut, the gut microbiota get damaged, and thereby the whole, system get the Helicobacter pylori, which gets even more, stronger foundation with all these things when our gut is not used to such kind of a food. I think we need to respect our boundaries and know how to keep ourselves healthy with our basic food. A day of partying is absolutely fine and allowed. We cannot go without that. We'll get, insane and mad, but we should know our limits.
Absolutely. And ultra processed foods are not really good. They're just energy dense. And this particular article, which I think came out in 2022, found that the incidence of both GDM and the preeclampsia increased when the intake of ultra processed food was very high. And, ultra processed food is controlled by a big industry. So we are never going to get the right answer for it, because there are, for every article that tells you there is an ultra processed food should not be used, the lobby has got another article ready to cause a confusion. But
the advertisement team is now very good. They even bring out the ultra processed food and name it for mothers.
Absolutely.
And we fall for it.
So that is why be very careful about the ultra processed food. We should not be using it. And just to update about it, there is what is called as the NOVA classification of foods, which, to understand the impact of industrial food. Now, we are not talking of natural food. A donut is not a natural food. A pizza is not a natural food. It's a industrial food. So what happens and whether there is any effect? So the NOVA classification has come in and it classifies. I'll show you in the next slide how the classification occurs. But remember that ultra-processed foods are energy dense, high amount of sugar, high amount of fat, high amount of salt, very low dietary fiber, low protein, low vitamin, and low minerals. So it's mainly junk is what we should be talking about. Okay, and the classification of it, this is the classification for those who are interested, that you have the unprocessed or a minimally processed food, which is what we generally are supposed to be eating as a part of our routine. Then you have the processed culinary ingredients, which includes salt and sugar. Salt and sugar were not a part of normal diet in our prehistoric times. But now it has come in, but they go into category 2. Then comes the processed food like cheese and those kind of products, paneer, those kind of products. And finally, of the ultra processed foods, which include the famous pizza and Coke. So the ultra processed foods are definitely a no during pregnancy. I think all of us should make it a point to counsel our patients that please do not use ultra processed food at least during pregnancy. Rest of the time you can do whatever you like, but not during pregnancy. Next, again, we go to Dr. Suma. Is there a role for dietary supplements? Do you think any of the dietary supplements, if we give, we can bring down preeclampsia or treat preeclampsia?
Definitely, there is a role for dietary supplements, sir, in prevention, mainly prevention of preeclampsia, wherein we have known extensive studies are there regarding calcium supplementation. And what they say is, if it is supplemented before or and very early in pregnancy, it is likely to prevent the development of preeclampsia. And even WHO has recommended that giving 1 gram of calcium starting from 16 to 20 weeks of pregnancy, it is likely to reduce the incidence of preeclampsia by almost to the extent of 55%. And also they have told that if folic acid minimum 400 micrograms, and also the vitamin D, which is containing more than 10 micrograms, it is likely to helpful in preventing the preeclampsia. And even we should also know that vitamin B6, its role has been known, studied that it is likely to decrease the homocysteine levels. So wherein there is, which is also a contributing factor for the development of preeclampsia. And one blanket statement we can make is the best diet for preeclampsia is always protein-rich diet, which contains fruits, vegetables, nuts, whole grains, legumes, and fish, vegetable oils. And also they have done the study that the pomegranate juice, so more helpful in preventing preeclampsia. And also the food which are rich in potassium, like avocado, banana mainly. So they will maintain the normal blood pressure levels in the body. And also they have done the study saying that guava fruit, it is mainly, of course, might not be having a very less relationship with the development of preeclampsia. It is also known to helpful in the development of CNS in the fetus. And the diet which they have advocated in preeclampsia is the DASH diet, DASH DASH diet, which involves dietary approaches to stop hypertension, where they have advocated, as I told earlier, the diet which is rich in whole grains, fruits, vegetables, and low fat. So what they have hypothetical statement they have given is diet rich in protein, less or no increase in the incidence of preeclampsia.
Absolutely. I think we are going now back to nature should be the policy in all our antenatal clinics. Lot of dietary supplements are being researched upon, and there are so many different groups in different phases, phase 1, phase 2, phase 3 trials of the dietary supplements that are going on. So much research, so much confusion in that research also. And the impact on preeclampsia, including nutritional supplements and dietary and lifestyle modification, has definitely been proved. Some studies have suggested benefit of vitamin D supplementation, but robust evidence from randomized controlled trials is lacking. So if you have to use vitamin D, please use it with caution after explaining to the patient that you do not have 100% evidence that vitamin D supplementation is going to help. And of course, like Madam pointed out rightly, a Cochrane analysis found that high-dose calcium supplementation during pregnancy reduces the risk of preeclampsia and preterm birth, especially in women with a diet deficient in calcium. Okay, now lot of other products are being worked upon. Starting from amino acid supplements, Chinese medicinal plant extracts, flavonoids, common grapevine, and so many other things are being experimented upon. A lot of articles are coming up. Unfortunately, very small trials. You really cannot conclude what is the point of it. Now, next we go to, I think the question goes back again to Dr. Suma only. Planned delivery versus expected management. We have been talking about this for a long time. Is there anything new in it?
Planned delivery, actually, we can think of, because as we all know, there is no point in continuing the pregnancy, and we are not going to gain much if the pregnancy is continued beyond 37, 38 weeks. And in fact, and this is the thing which I got, sir. So it is always better to continue as much as possible, keeping in mind both maternal and fetal surveillance, and if everything is normal, continue till 37 to 38 weeks, and not to go beyond 38 weeks. So in that way, expectant management will always helpful.
Sure. This is an article from August 2022 that there is a limited evidence regarding the optimal time of delivery in the late preterm preeclampsia. Early preterm is a different cup of tea altogether, early preeclampsia. This is the late preeclampsia, and planned delivery in women with late preterm preeclampsia provides clear maternal benefits and may reduce the risk of the infant being born small for gestational age and possibly an increase. This benefit comes with an increase in the short-term neonatal respiratory morbidity. So you get good benefit for the mother, but you may harm the baby a little. The potential benefit and risk of prolonging the pregnancy complicated by preeclampsia should be discussed in women as a part of shared decision-making. We are into an era of respectful maternity care. Any decision should be a shared decision. Your job is to counsel the patient that, look, if I deliver you today, these are the advantages, these are the disadvantages. What would you like me to do? So a shared decision is now what is more important. And the summary of the findings of this multicentric trial was that the eclampsia falls by about 50%. The relative risk becomes only 0.5 for eclampsia, 0.6 for renal insufficiency, for HELP syndrome also 0.5. Surprisingly, we generally presume that placental abruption is going to be more common with preeclampsia, but in this particular trial, they found that the risk ratio remained around 1.02, that is almost the same. But what is more important to see is the respiratory disease, the RR is 1.41. So you're giving some benefits to the mother, but you're also causing a disservice to the fetus. So keep both this in mind and then do a shared decision. And finally, we come to this one question of, we have been ignoring the mental health of pregnant women generally. Pregnant and post-delivery women, all of us tend to ignore their mental health. What is more important is this preeclampsia severely affects the mental health of a patient. So, Dr. Shashwati Sanyal, does preeclampsia really affect the mental health? Does it cause problem, any psychological issues to the patient?
I think it is already a fact that is known, because all primigravidas, they get preeclampsias. They are on mental stress. So this definitely, there is a direct relationship with the mental health. Depression and anxiety in the first trimester has got a 2 to 3-fold high risk chance of preeclampsias. And because it is mediated to neuropsychoimmunological pathway, and we have seen the patients, those patients who are having the premonitory signs of a severe form of the disease. Initially, the patient comes with some mental problem. Actually, this is a neurological involvement of the preeclampsia, because that's the same the mechanism by which the psychiatric disorder also comes into play, in the form of there is probably an anti-angiogenic factor and pro-inflammatory cytokines from the placenta damage the blood-brain barrier endothelium, and that can give rise to long-term structural and functional cerebral changes. These are the hypotheses that has been made nowadays. And we have seen that preeclampsia even increases psychological development disorders in children, which is 2-fold high in the form of schizophrenia, ADHD, and autism spectrum. So there is a relationship between the preeclampsia and psychological, the mental health of the patients, whether it is present before or even after. Because postpartum, after this preeclampsia, we have seen the postpartum health, there is an increased risk of severity of cognitive impairment, psychosocial distress, depression, anxiety, and PTSD. So these are the relationship between the antenatal periods and the postnatal period, and even in the children.
Absolutely. unfortunately, the father of preeclampsia, Chesley, had said that once the patient with preeclampsia delivers, there is no more issues. Treatment of preeclampsia is delivery, but now we have more and more proof that preeclampsia is a lifelong disease. And one of the important points is that it even includes the mental disturbance in the patient lifelong, not just in the immediate postpartum period, but even later on in the life. That happens because the anti-angiogenic factors and the pro-inflammatory cytokines can damage the blood-brain barrier, so that there are long-term structural and functional cerebral changes, and there is a subsequent impairment of in mental health. So again, all of us should make it a point to ensure that we look into not just physical health of our pre-eclamptic patients who have delivered with us, but also into their mental health, and counsel them that you need to watch out for all these problems.
Excuse me, sir.
Yes.
Even it has been advocated that these pre-eclamptic women are likely to have depression. So they have associated the incidence of depression in association with increase in the cortisol level, which is seen in case of preeclampsia also. So advocating slow breathing exercises, they are likely to stimulate the CNS and they are likely to decrease the levels of cortisol. So wherein there will be improvement in the psychological aspect in the pregnant preeclamptic women.
True, I don't think the day is far when you will have a yoga instructor in every obstetrics department in the country. It's going to help a lot.
Yes, sir. Yes, definitely.
Then we have, of course, the new biomarkers coming in. We know SPLT-TLGF, we know glycosylated fibronectin, but many more biomarkers are being worked upon now that includes the RNA species, the DNA, certain metabolites, certain proteins, and all these are what is going to come up in future. Now, with this, we go to the last part of our panel. What are the strategies to improve outcome in community? We are ready to improve ourselves, but just by improving ourselves, the problem doesn't end because the woman can come to you very late. So we need to improve the strategies in the community, and we need to have what we call as the basic science research, then translation to the humans, finally translation to real patients, and then translation to practice, and finally translation to community. A lot of things we have reached up to translation to practice, especially by our VLSPE. We have made an attempt to reach that we reach the translation to practice, but now is the time to translate it into community action. So if we have the researchers and healthcare providers interaction, followed by the interaction between the healthcare providers and the community, we are definitely going to have a better outcome. Now, from my personal angle and from the Society for Maternal Fetal Medicine, we have been doing small things to improve this kind of a community outreach. One, of course, is the virtual learning series. The second one is we have managed to get the International Society for Study of Hypertension World Congress to Bengaluru. We are hoping that a lot of things will come out of that. On that day, we are going to start a patient advocacy program. All of you are aware that there is a Preeclampsia Foundation, which is mainly concentrating in the Western countries with few centers in Africa. But in Asia and especially in India, we don't have a foundation for our patients where they can voice out, where they can interact with each other, where they can support each other. And so this Preeclampsia kind of a foundation, a patient advocacy program, is what we are going to have during one of the workshops in the Congress. And of course, from my personal angle, I've been trying to make sure that I train some doctors, especially I've been going to Mizoram to train their doctors so that the eclampsia and of course the postpartum hemorrhage, both of them I'm training them would come down. Now with this, I would ask our three members to talk about their program. First, it will be Dr. Shashwati Sanyal talking about training of healthcare workers in Assam. That will be followed by Dr. Suma for training of staff in the sub-district hospital and PHC in Mysuru district. And finally, Dr. Gayatri will tell us about firefighting preeclampsia in Tamil Nadu. Dr. Shashwati Sanyal, please.
I think this is the most important area because
Dr. Shashwati, I basically included these questions because Again, as I told you, a lot of youngsters are listening to us on the platform outside, not just on the current platform. And then later on, when it comes on the YouTube and Facebook, people are seeing these programs. And I'm hoping that the wise words coming from you people will stimulate at least a few persons outside so that they also start off such kind of projects. Yes, Dr. Shashwati, please go ahead.
Yeah. So we have actually the program is always there. You know, the Government of India has got lots of programs for these trainings, but the coverage is sometimes it is very, very, I mean, it is not a very good one sometimes. So every year we are increasing the target, the coverage. The coverage target has been increased. We want it to be in the next session. We want to become the 90%, that antenatal coverage, ANC coverage. And we also wanted that identification of high risk pregnancy, which is our, I mean, the mainstay of the identification of the cases who are going to develop preeclampsia. Then we want them at least, if it is the incidence of a high risk pregnancy is around 15%, then we want at least 12% of them should be identified at the ASHA level or the grassroots level, A&M level. This is the most important part of the story. And even government, they have also done a case-based incentives. So if they can find out those cases early, then it is easier for us to manage, as well as we have some preventive aspects. So this is an important area. And even the HRP, say, for example, if the patient, the nurse has given magnesium sulfate to a patient who is in hypertension, the percentage of that HRP managed, we also know as high-risk pregnancy managed, it should be around 85%. That is, the patient, when they are found to have a blood pressure of 160 by 110, the first dose of magnesium sulfate to be given at that point itself. So, but there is a problem of this in a magnesium sulfate, because a lot of nurses, they think that whether they have knowledge, but they have a problem of understanding how the procedures of giving it and the complications, and they're scared actually because of the monitoring part. So for that we have the dakshata training. So all the nurses are given that particular dakshata training, and because we know that the Lakshya has been also been implemented in Assam, and we want a lot of other places. This all the state hospitals and the PHCs, they should come under this Lakshya guidance, and a lot of work has been done on this Lakshya. The doctors from the medical college, they go there, and every month they find out how much improvement they have done in that Lakshya, the quality management. And we have Surakshit Matritva Ashvasan Suman program. And of course, we have that JSK. And we also have an area which is called Shobhagya Mother and Baby Center in close proximity of the district hospital, where there is high case load facility, and so that the mothers who are, because they cannot stay in the hospital because the hospital has that restricted place. I mean, so they are placed there. If they stay further from that DHS hospital, district hospital, very far away from that, so they are kept in that Shobhagya, and their food and everything is covered under this particular program. So the lot of things has been done, and in fact we are improving, and because we were the worst maternal mortality in the country, but we have improved. We have come from more than 300, we have come down to 185 or 175 at this particular moment. So a lot of work has been done. Our government is very, very keen for this, and there are so many audits are being done for the maternal death in the community level. Of course, the facility-based level is also been done, but in community level also it has been done and very elaborate. And our district, DCs, they are taking a lot of interest in this particular, which has been held regularly. So unless we audit it, then we have to try to find out why this patient has been missed, why this has not been taken care of. So a lot of training program and the auditing program is going in this particular part of the country, because we are very much eager to reduce that maternal mortality.
Thank you, Dr. Shashwati. Dr. Suma, your experience, please.
Yes, sir. Actually, as Dr. Madam Shashwati Madam told, so that Daksha program and Lakshya program, they are all implemented from Government of India. So it has been uniformly, it has been tried to be implemented across all medical colleges, mainly the government medical colleges. And most so important thing is the periphery, because medical colleges, most of the time they will be in the city level, and the management won't be of much difficulty, because ANMs and ASHA workers will be in the periphery. They are the first contact with the patients in the rural areas. So there are extensive training which are going on, which will be done under district level, wherein these people, these ASHA workers and ANMs have been trained to detect the blood pressure, how to check the blood pressure, and reading of 140/90. So if that is there, because they are not that well trained with management, they will be asked to refer the patients to the higher or first referral unit. And even in the first referral unit, most of the time doctors might not be there. Even if the doctor is there, might not be a qualified gynecologist. So all the doctors have been trained at least in giving, because now that injection labetalol also is being provided in the government hospitals also. So at least give in the one injection of labetalol if the qualified doctor is there, even injection. And also if the blood pressure is more, or if they all will be trained regarding identification of the imminent signs like headache, vomiting, all those things. So headache, vomiting, not only thinking in terms of gastritis or any other headache. So increase BP recording and these imminent symptoms, there is nothing wrong in giving magnesium sulfate also. So because they are not that well trained in monitoring and giving intravenous injection with dilution. So at least give 5 grams of injection IM and shift the patient to the either to the district hospital or to the medical college hospitals. So in this way, more and more training is happening to the at the rural level for mainly training the ASHA workers and ANMs, and also in the primary health centers where only the medical MBBS doctors are there. So they all will be trained in identification of the early warning signs and giving injection labetalol, or at least even if they cannot give injection, they will be advised to give at least 110 milligram tablets of the women can be asked to for nifedipine. So that can be given, and they can be, and even I heard because even though I'm working in a private medical college, I heard from the government medical college faculty that because monitoring on the way, shifting from the peripheral or the village to the city, to the medical college or the district hospital, it takes some time, and there might be some problem in monitoring the women. So they always sometimes they will even though the giving sublingual nifedipine is contraindicated, sometimes they will ask at least keep the tablet, because sometimes the women also might not be in a conscious condition. So if they cannot, they just try to keep on tablet sublingually, because that is what they told me. But I am not that very sure about this. But otherwise, first reference, identification of the warning signs and recording of blood pressure, that extensive training is going on for peripheral women who are the first contact with the pregnant women.
Yeah, thank you, Dr. Suma. I've been a mentor for Lakshya, and I found that the thirst for knowledge among nurses especially was very high. Somehow I have to say the doctors were a little less keen, but the nurses were very good in learning, picking up things, wanting to change themselves. So that has definitely been happening.
I just
Yes.
want to share one innovative thing that has been done in now one of our peripheral hospital. This is near Guwahati, where they have a device. They have one device has been invented where the ASHA has been trained on that the patient puts the hand up to the wrist and they find out the blood pressure, pulse and everything. And that is being attached to a cloud which immediately goes to the doctor. This has been done with some Don Bosco University, some postgraduate students. So this has been trained. The ASHA has been in this particular app, 2 or more ASHA. A pilot study has been done and it is already been published that these ASHAs, they are trained in this, which is a very simple app, and they just get the data and it immediately goes to the cloud and the person concerned, which immediately gets the, that this particular patient in this particular area is been. So this is the new thing that is also coming.
I think technology has helped us to reach a lot of remote areas.
Yes.
Dr. Gayatri, firefighting of preeclampsia in Tamil Nadu?
Sir, I would like to share what is actually happening in Tamil Nadu. I think this initiative started around 5 years back, definitely pre-COVID, where we were, it was a government of Tamil Nadu initiative, where they introduced something called the RCH number or the Pick Me number, the reproductive and child health number. So first thing was they brought it up and said that without the RCH number, you cannot have a birth certificate for your child. And to get that RCH number without a problem, you need to have an early booking. These two conditions were brought about by the government, and hats off and great salutes to whoever were the brains behind this. Because now, whoever you are, you need to have your pregnancy registered with the government, whether it is an ectopic, whether it is an abortion, whether you want an MTP. And all the private hospitals, all the private gynecologists and the MBBS doctors who are giving gynecological services to the patients were called for a government meeting, and this was emphasized to us. So once we started getting patients for early booking, we started emphasizing on early RCH number registration. And for this RCH number registration, each and every area in Tamil Nadu was associated with a primary health center. So each and every person has to go to that primary health center, meet the nurse there. That nurse is not even a qualified nurse, but the local community worker, like our Asha or anybody, who is in charge of getting the number for this patient from the portal. So each and every primary health center caters to around only one area, and that area is likely to have around 10 to 20 pregnant women at any point of time. So this nurse is in charge of that 10 to 20 people. And that 10 to 20 people, when they are registered, now we have the computers, we have the softwares everywhere. So we also have the phone numbers of those patients with us. So now the responsibility is both with the private and the public. And in Trichy, sir, there is a wonderful coordination between the private and the public. And we have a WhatsApp group where all the gynecologists who are delivering numbers are in that, along with the district director of health services and the joint district director of health services and the district maternal and child health officer and everybody who have direct access to this RCH numbers. So when I see a patient in my OPD and I see that her BP is a little higher and I want her to come back for checkup and other things. Now the basic major problem we all have to realize is that now the miscommunication and the mistrust between the doctors and the patients. When I tell my patients, you have a slight higher BP, Rakana, you need to come for follow-up. The community and the house, the neighborhood advisor, oh no, there's nothing called BP in pregnancy. The doctor's trying to do a cesarean on you. So that is why she's telling in pregnancy. And this kind of they don't allow us to focus, and this kind of a wrong misguidance and other things. Now, when I see that patient, I take up her RCH number, her address, her phone number, and put it in that WhatsApp group. Once that WhatsApp group it is there, the district maternal health officer finds out that nurse who is in charge of that person, and the nurse goes home and counsels her. No, there is something true. This could endanger your life. She goes home, takes BP of the patient, takes photograph of her taking BP of that patient and posts it in the group so that we have a perfect follow-up, sir. Because of this, we are able to very effectively bring down the, at least very important things. This was very helpful for us when we had this flu outbreak. We were able to give the Australian tablet, the anti-flu tablet to the patients. We are able to bring down the COVID and COVID mortality because of this. This is very, very strong in Trichy district. And this was a government of Tamil Nadu initiative. And I'm not sure how much in other state it is there. But I'm very sure, sir, if this is really strengthened. And when I had a patient with a fever postpartum, and the patient was not very, keen in having a follow-up, the district director of health services sent his people to counsel the patient. No, you're very well taken care of. You please listen to the patient. Listen to the doctor. So they have a better, confidence in the medical field in what is happening to them. Because of that, we are very effectively able to bring down eclampsia things, and we are able to do that, sir. I think this is really good, and we should take it forward to other states and other districts as well.
Yeah, really.
Yeah, definitely. That's
Fantastic.
And so we all know that by good cooperation between everybody, we can bring down the preeclampsia down. Thank you all very much for being a part of this conference. Thank you. I'm sure our delegates have learned a lot. Thank you, Dr. Suma, Dr. Gayatri, Dr. Shruti, Dr. Shashwati Sanyal, Thank you for being there. And I hope we have sent across some clear messages and will make some difference to the woman out there. Thank you.
Thank you, sir, for the opportunity.
Thank you very much. Thank you, everyone, for giving us this opportunity to be associated today.
It was indeed a very eye-opening one when, in fact, sir had told that he would be making everybody speak about the innovations that they are doing in their field of work at their place with respect to preeclampsia. I personally never thought that it would be something like this, where lots of things are happening, lots of interagency cooperation. The government is helping, the nurses are helping, the doctors are helping. There's lots of awareness going on. There are lots of, like ma'am said, there are IT students from tech colleges coming down to help us with our medical problems. This inter-agency or interdepartmental help that we get can definitely let us curb the progress, onset, and probably even help us prevent deadly disease like preeclampsia. With that, I would like to invite back Dr. Revati to give us a few updates and what's new about our PENAI program, the Preeclampsia Education of the Nation program. So usually we used to do something called after the making of PENAI, where we say, okay, this was how the making of PENAI happened. And that happened for about three of our VLS series. We just had to say about what is PENAI and how we made it. But now we have the updates. It's growing. The root was there. The stem has been there. Now there are lots of branches to it. The leaves are coming up as green. So I would hand over the stage to Dr. Revati to talk about PENAI and more about what is new that is happening in PENAI.
Thank you so much, Anu. And it's really a privilege to be actually talking about Preeclampsia Education of the Nation, India. And we definitely want to say that this VLSP started because we had inaugurated, or we had started the PENAI program, and we wanted just not the recruits to benefit from preeclampsia education, because PENAI is an online course. We wanted everybody, because this VLSPE has been taken by delegates from across the country in a very big way, because it's very simple. There is a link and you can just log in and you can listen to preeclampsia information. Necessarily, you have a capsule which is about something new, and then a panel from representation from all over the country, and then of course about the PENAI progress, and maybe a lot of motivation from the PENAI delegates, so that you can probably pursue this course seriously. And of course, our inauguration of other academic initiatives of the SMFMI, which revolves around preeclampsia. So yes, Preeclampsia Education of the Nation, India was an idea that started off in 2020. And this is, let me tell you, the first of its kind in the world, where we thought of certifying practicing obstetricians and gynecologists. We started off with an idea which stemmed out in Bengaluru, and it was made for Indian doctors, using teaching modules with the latest updates on hypertensive disorders in pregnancy, with special emphasis to preeclampsia. It's a collaborative project by the Society for Maternal Field Medicine India and the International Society of the Study of Hypertension in Pregnancy, which is currently the highest authority which sets up international guidelines globally and not just restricted to a particular country or particular geographical area. Now, I cannot move on with the progress unless I say a few words about what this PENAI is. We have some regular attendees who know a lot about PENAI. We have had a lot of attendees convert to PENAI. We've had a lot of certified delegates training several others. So this is happening in the background. If we have trained and certified 100 doctors, it is multiplying at geometric proportions. We might have at least another 500 more who have been trained. So, in their medical colleges, in their clinics, everywhere. And so we invite all of them to be part of a certification program at the iShip World Congress, because we're going to have a mini PENAI certification course at the iShip World Congress, where you can do a pre-test, post-test, listen to the most important information on preeclampsia, and carry a certificate, and then maybe, if needed, go. I mean, you can always enroll to the I mean, I wouldn't say if needed, you would definitely want to enroll to the bigger preeclampsia course. Now, what is very, very important for us to understand is, this course started off because there was no definite course which had everything about preeclampsia, starting from the definition to the recent advances, starting from the Indian scenario to the global scenario, starting from the practicals to what is new. And so we wanted to put everything in a nutshell. Suppose everything can happen over a period of 8 hours. It is very easy for any obstetrician who are mostly very, very tied up with their patients. So I should really thank Sir for motivating us to do this. Dr. Prakash Mehta has been the Indian co-chair, and maybe because of his constant mentorship, all of us are so much induced into preeclampsia. So we are always thinking, talking, doing preeclampsia. And so we started this program in 2020 with Sir and me being the co-chairs from the Indian perspective. And we had Dr. Sarosh Rana, who was the international advisor for Society for Maternal Fetal Medicine, who is the global co-chair. Now, I've already told you why we want this course. And the whole idea of doing this was to create a virtual model, have about 5 learning modules and 1 assessment module. It was a lot of brainstorming discussions, because we wanted doctors to be very committed. There was a very nominal fee. The doctors had to go through the modules which were designed had faculty who had done exceptional work in the field of preeclampsia from India and abroad. And they had to finish all the modules and then necessarily take a test which had MCQs and also clinical case-based discussions, and then pass out with at least a 75% score to call them certified. This was to make sure that we had standardization of the recruits from the start till the end, and we could empower them literally so that they could train, because it's very difficult to reach out to every person. If you do it practically, there are so many problems. But when we have trained someone, we should be motivating them to train many more. And that's what Preeclampsia Education of the Nation is doing today. And I'm so glad that Dr. Sarosh Rana, who is now going to be the secretary of the iShip, would want to do this as a flagship for the rest of the countries in the world. And we would say it with pride that we started in India and it's doing well. And I really thank Roche for funding us for the pilot initiative. So they helped us with, they funded the project initially at the pilot stage. They also helped us to source some of the recruits. And we've had several other knowledge partners. We've had Medinet, who has been our hosting partner. We've also had Shield, for instance, who has helped us to carry the essence of the program across the world. We've had several people who've actually helped us to identify the delegates to, recently we had an on-site program at Mysuru. So we had several other support systems who helped us to do the on-site in a very big way. And I have projected this slide because you should know that we start from introduction to actual problems of preeclampsia, to recent advances, to clinical challenges and cutting-edge concepts. And believe me, every single faculty here has done great work in preeclampsia. They've been excellent in their jobs, and listen to their talks. And I'm sure that they're going to inspire you to do much more. And I'm sure you're going to create such modules in wherever you belong to and take the message of, joining hands to save lives. So basically, I should really thank a community of about 30 to 35 doctors in Bengaluru who actually were the implementational team who brainstormed mostly every week to set up these modules. The SMF, my office, also gave us all the hands. And then we also had the VLSP program. So this is how our convocation looked. It was a virtual convocation. And we also had the certificate. We had an interactive session where Dr. Sarosh Rana and both the co-chairs from India answered the questions live to the passed out delegates. And it was a great experience because they were telling problems that they actually faced in their OPDs and got a big discussion, launched, which probably was streamed worldwide. And this is about, we also gave them a downloadable format, which they could probably keep it as resource material and use it for teaching. And I hear it from a lot of delegates that they have actually used this to propagate PENI information or preeclampsia education to their postgraduates, to their nurses, to the patients. And it's really satisfying. So this is how our feedback form looked. And then this was only on the online series. We have had about 103 recruits. We've had about 35 completely certified. And there are lots of people who have finished the course, have not taken the assessment. They are in the process of finishing. So we are in touch with them because we cannot certify them unless and until they actually finish the course. And recently we had the PENI on-site at the Mysuru campus. We realized from our experience that online may not be a totally doable thing because there may be a lack of pursuing the concept, up to the 6th module. So we had some suggestions that we should probably look at the on-site version where we can identify these delegates who can come as a group, maybe as a society representation or a medical college representation. And then we put in all the teaching modules, starting from the morning and finish it over a period of about 6.5, 7 hours. They are all played. These are all standardized video modules. We cannot change the content. And then finally, they take their online assessments at home, and it really worked wonders. We had 40 people certify out of 57. Let me tell you, 40 may not be a big number, but these 40 can motivate another 400 people, and that's how this is going to be a vicious, I wouldn't say a vicious cycle, a chain reaction, educating and empowering not just doctors. We have also thought about including integrated medicine doctors and nurses in our iShip World Congress for the mini PENI certification program. So I welcome all of you to, there is a package for anybody. You could have an online one, you could have an on-site one where we could do it in your place for a period of 6.5 to 7 hours. And we have also evolved to an on-campus program where we are actually looking at medical colleges. And I'm really glad that Rajarajeshwari Medical College has taken up this initiative. I congratulate both the Mysuru team who hosted the on-site, which is again a fresh information. We had inaugurated the last time, and now we are telling you the results. And we are also congratulating the on-campus version now. We are inaugurating it, and hopefully in the next VLSPE, we will tell you about what happened in the on-campus. We want to go to every medical college and certify all the clinicians for preeclampsia. Now, it is very simple. You just have to approach us. I will show you my email ID. We will always share you the email ID, and we can organize it on a day which is convenient to your department. We can come to your medical colleges. You can get at least a group of 30 people to participate, which could include consultants and postgraduates alike. You could also get people from, say, general medicine or any other department who would want to listen to about preeclampsia and certify. And once the program is over, you can go home and take the assessment within 2 weeks of the completion of the program. Submission of feedbacks will probably give you the certificate. It's going to be very nominal. The fees it is just a commitment fees, and we can probably, the earlier online version was about 4,500, but it could be even much more less than that. And, the on-site, I think it costed very little to the delegates, and we can probably customize it for you, and you can certify for the course. We also have the webinar version, which we have still not implemented for all those people who were not able to complete the course. They can do it in a supervised manner. There will be a PENI coordinator hosting that session as a weekly webinar over a period of 5 weeks, and then you certify with an online assessment. If you have not finished a particular virtual module, you can still take that module under supervised moderation by the PENI coordinator. You can ask questions because sometimes it is really tiring for somebody to just go on reading the modules one after the other without interaction. So this is available. So name it and you have it. You want to have preeclampsia education, you have the online, you have the on-site, you have the campus, you have the webinar, you have the mini PENI, and so on and so forth. And you have it, and probably you will have it in all parts of the world. So, and I'm so glad, like how Sir mentioned, this has given us the iShip World Congress is coming our way, and all the proceedings in the iShip would be teaching modules again. And I'm very, there is a thought that we would probably propagate this as an updated Penai module, maybe, after the World Congress, but be there and meet the researchers and be a part of the scientific deliberations. So definitely, we've been always talking about the future. Every day there has been a different opportunity, a different method, a different version. And I really congratulate each and every person who has made preeclampsia education of the nation so effective. And I would definitely want to, speak about our on-campus version. We would want to do the inauguration and also talk about its results in the next version. And, think about what are the other things that we would probably join in line after these versions. So it is important to deliberate and discuss. It is important for us to educate and empower. These are the solutions, whatever be the field, whether it is preeclampsia or any other medical problem. We need all this in place to make, treating patients scientifically relevant and reproducible. So thank you so much. We have our YouTube archives. You can actually approach us anytime. We are just www.smfmi2017@gmail.com. Just approach us and we can give you any information on the VLS or the Penai program, and you can watch it from your doorstep. This is our dream conference, Pragna. We invite you, please be part of this. Register in bulk, register in groups. We will customize very good discounts to all of you. And this is our correspondence details. And thank you so much. So I think we will move on with the most interesting thing about the inauguration of the on-campus version. Before we have we have Dr. Hemapriya talking about the on-site course. Thank you so much.
Thank you so much, Dr. Revati. Next, I would like to invite Dr. Hemapriya. She's been a part of our VLS series in VLS 6, and she's also completed and organized the Mysuru Penai program. Dr. Hemapriya, are you online?
Yes,
Hi.
Dr.
Hi, Dr. Hemapriya.
Hello. Good morning to everyone.
Hi.
Dr. Prakash Mehta sir, Dr. Revati ma'am. Good morning, everyone.
Dr. Hemapriya, would you like to introduce yourself and give us a short feedback on how the Penai program was for you and for your colleagues who attended it?
Sure. I am Dr. Hemapriya. I am an associate professor in JSS Medical College, Mysuru. So along with Dr. Sushma Dev, who is an associate professor in MMCRI, she is the president and I am the secretary of the Mysore SMFMI chapter. So it was a initiative which was led by Dr. Prakash Mehta and Dr. Revati. We actually brought the Penai program to Mysuru as an on-site program. Probably this was the first of its kind of the Penai program, where we had this program in February, where we had 58 participants. It was an 8-hour session where we had all the 5 modules, one after the other. So all the delegates, they were able to enjoy it similar to a one-day CME, but rather these were more practical points. It was not like your usual CME where you just attend the talks and you go back home. This also had a post-test assessment. So the 6th module, which was the assessment, we took it online, maybe within a week or 10 days after the assessment, after the program. All of us took the assessment online. And the unique part of the assessment was that everyone had different question papers. So it was not the same, like you cannot discuss and mark the questions. Although they were MCQs, it was really an eye-opening session where we learned a lot of new things, especially for prediction of preeclampsia. Majority of the things, the clinical common private practitioners may say that it is just a research. But no, definitely that research is translating into clinical practice now. So what feedback we got from all our local members who participated it was not only useful for the postgraduates, but also for the practitioners who got a chance to brush up their knowledge, to brush up their clinical skills. And with the assessment, we could actually make out like what are the recent advances and where we stand. So I think majority of our people have cleared the assessment. Some of them could not clear. Some of them could not attempt due to personal reasons. But all in all, everyone had a great time and it was a good learning experience for everyone. So once again, I would just like to thank the organizers for making this possible. And we also have actually a lot of requests for one more session for the people who could not join in the first time. So they want to have one more on-site program. So we're just deliberating on that. Thank you very much.
Thank you so much, Dr. Hemapriya. Dr. Revati is evidently very happy about it.
I'm trying to put something on the chat.
So that was so nice. Thank you. Thank you so much, Dr. Hemapriya. Next, I would like to call upon Sir once again for starting with our inauguration ceremony for the on-campus program. Dr. Sai Lakshmi, HOD OBG, has joined us from Rajarajeshwari Medical College. Dr. Shruti has been coordinating with Dr. Sai Lakshmi for quite a long time for making this happen. We at the outset thanking you, Dr. Shruti, for taking the initiative. Sir, handing over the mic to you.
Yeah. Good morning again, everyone. And the online program had been running for quite some time, and we thought that we should start with the COVID gone. We should start lending a personal touch to the program so that we spread this knowledge of preeclampsia. Of course, the first session, like Dr. Hema said, was in Mysuru, and that was a great success, which really propelled us to do things more and more. And now we have the Rajarajeshwari Medical College coming forward with their batch of students, and anyone else who is interested to participate on that day for the online program. One of our very young members, Dr. Shruti, has been working very hard towards making this program successful. Thank you, Shruti, for that. And the whole idea is, to make sure everybody comes in contact with it and learns something from it and changes their practice. So with this, I think we could, Dr. Sai, there.
Good morning, Dr. Mehta.
Good morning. Yes, ma'am.
Hi, good morning. Good morning to everybody who is attending this meeting. I'm very happy to say that I'm very happy to be a part of this very nice program, because we all know what magnitude of maternal mortality and morbidity is caused because of the hypertensive disorders of pregnancy. And I should thank Dr. Shruti for including us in this program, and also Dr. Prakash Mehta for considering our hospital for this program. And hope we'll have a very nice interactive session, sir.
Yes, sure, ma'am. Definitely.
And I think the dates have to be fixed up for this program. Some last week of May was the thing which tentatively Dr. Shruti told us.
Sure, because we have one more program in Vaidehi Medical College also. So Shruti, just interact with Harini and fix up the date.
Yes, sure.
Yes, sir, we will be all out, and we'll go all out, and we would like to include some of the faculty members also, sir. Is
Sure,
there any?
definitely.
Yes.
Definitely. It will be a pleasure to make sure some people are definitely there.
Yes, sir. Yes, sir. We will include, sir. Anything from our side, we will definitely do our best.
Sure.
And we would like to have a very interactive session.
Thank you.
Chitrakala, can we have the inauguration slide on?
प्रणमाम्यहं श्रीगौरी सुतं प्रणमाम्यहं श्रीगौरी सुतं प्रणमाम्यहं श्रीगौरी सुतं प्रणमाम्यहं श्रीगौरी सुतं हनितपवसुदेव भक्तौ सततं प्रणमाम्यहं श्रीगौरीसुतम् अणितल्पवसुदेव भक्तं सततं प्रणमाम्य गौरीसुतम्.
So with this, we hope to go to more and more campuses on site. Our aim is to first cover as much of India as possible, and we already have candidates coming in from Nepal, Bangladesh, Afghanistan, and so especially countries like Afghanistan and Pakistan. We know that their healthcare is suffering quite a bit, and we would definitely like to help the women across over there. We also have offers from Kenya and from Haiti to help out with the preeclampsia management over there. And we hope to do as much as possible. We know we can't do everything, but I have a good team of young members who are very enthusiastic, and we hope we'll do as much as possible.
As a part of our Preeclampsia month, I believe all of you know that May is considered as a time to celebrate, understand, and spread awareness about preeclampsia. And it's just around the corner from tomorrow. There are a few programs that we have tried to organize as a part of SFMI as well as a part of NI. Dr. Revati, would you like to talk a few words about the Preeclampsia Awareness Month and the programs that are in store?
Sure, no, it's again a great preeclampsia privilege. And see, this is something that just stemmed out of our idea box last week when we were probably discussing with a whole lot of preeclampsia advocacy groups from across the world. In fact, Sir and I participated in this virtual meet, and we found we had representations from the US, Australia, from Africa, from Europe, from Australia, all connecting, and all of them were thinking like us. So it was a group of like-minded people who wanted to just not talk about guidelines and implementation and research, but also talk in terms of the patient perspective. So we are definitely wanting to do this in a big way. Awareness is not just about involving the doctors, it involves the healthcare personnel, the general public, the patients, their families, the survivors who can probably, motivate other people, other patients to do the right things. So this prompted us to do what is called the Promise Walk, that yes, we will try to fight this disease together. We don't want to do it alone. So there is just an idea which has stemmed out now, and we want to probably do this maybe in the second week of May. We will send all the specifics very soon. So it's going to be a walkathon somewhere in the starting at the center of the city, but we also invite you all to participate in your own way. You can do it in Mysuru, you can do it in Mandya, you can do it in any place, but the concept should be for awareness. Join hands, express your solidarity, and spend a few hours saying we are all there to to help you surmount this problem. So please contact us at smfmi2017@gmail.com. We will share more information about how you can participate. We are also going to have some very interesting incentives. We are probably going to open up some interesting prizes for postgraduates and consultants who will dedicate their time for this walk, which we will be announcing very shortly. So please let us all join together, not just in the month of May, across the whole year. And that's what we do with the VLSPE every day, every minute, to fight this problem called preeclampsia, which is a sinister between any mother who's having a problem during pregnancy. It's not defined always, but it is there in every difficult pregnancy. So let's all join hands to save lives.
Yeah, I would especially request to all those who are from outside the city of Bengaluru to see if they can arrange such a program in their own place. We are always there to support you and help you. But as anything, let us not look at hundreds and thousands walking across. No, even if a small group of 10 or 15 does a small walk, the awareness will spread across that place. So please do whatever you can in the month of May to spread the awareness of preeclampsia.
Dr. Revati, that's all.
Yes, it's a lot. I know there is a lot to unwind.
Yes, I'll get into my area of expertise.
I think there is
Photo
going to be a video, a promo video, Anu, before
yes. So this is about our ISHP 2023 conference, which is to be held in Sahiti, sorry, Chitrakala, you can switch on the video also. It's about the ISHP conference. We wholeheartedly welcome you all to attend the conference.
Join the International Society for the Study of Hypertension in Pregnancy and the Society for Maternal Fetal Medicine, India, for the ISSHP World Congress 2023. A global summit on hypertensive disorders and pregnancy. This year's theme, Pragna, aims to build awareness and make progress in this important field. Join us for our physical conference on September 24th to 27th, 2023. Save the date and don't miss out on this unforgettable experience.
We are hosting this conference from September 24th to September 27th, 2023 at Bengaluru, India.
We are here to welcome the researchers and scientists from across the world who have done exemplary work in the field of hypertensive disorders in pregnancy with special emphasis on preeclampsia. There are going to be several interactive workshops, including the preeclampsia education of the nation, India.
So I'm really looking forward to have a very robust participation, especially from our Southeast Asian colleagues, hoping that I will see a lot of you people in person.
Attend our 4-day academic fest featuring national and international experts with the option to participate in physical sessions or virtually. Take part in workshops, interactive sessions, and networking events, and explore the latest products from top companies in the field at our Grand Expo area. This event is hosted in Bengaluru, also known as the Silicon Valley of India, a city of gardens, technoparks, and multiple languages. Don't miss this opportunity to expand your knowledge and skills in a vibrant and exciting environment.
Chitrakala for that playing those videos. Now coming to the last corner of the program for today is a vote of thanks. Definitely, I would like to extend my heartfelt thanks to Sir and Dr. Revati to have guided us through this, to have made us organize this, to make sure that we have, went ahead with it, did not stop in between. We completed all the 6 that we had planned for, and I hope there are more of the VLS series coming up, educated more and more people about different diseases, and then we go forward with it. Thank you so much, sir. Thank you so much, Dr. Revati. Next, I thank all our participants. Dr. Saswati, thank you so much for showing us that, there needs to be so much done into the research. There is so much that we can do in educating not just the doctors, not just the healthcare workers, but also people around who can help us by making them understand that there is a problem and we need a solution to it. Thank you for your very encouraging words, and also thank you for the brilliant outlook that you gave into the field of research in preeclampsia.
Thank you.
Dr. Gayatri, thank you for joining us and giving us the insight into how the government can work towards helping us in the medical problems that we face, and how as a team you have worked so well in managing the problem of preeclampsia and other problems in pregnancy as well. Thank you, Dr. Shruti, for joining us for the panel, as well as making sure that the inauguration happened smoothly, and we are getting to have the on-site programs also, on-campus programs also being rolled into our Penai program. Thank you so much, Dr. Suma, who joined us from Mysuru, for her insights into the various aspects of preventing preeclampsia, not just by aspirin, but also other modes like exercise, yogas, and other things. To Dr. Sai Lakshmi, thank you for having us in your college, for starting with the on-site, on-campus program. Thank you for giving us the opportunity and also starting with the initiative of this. Thank you for believing in us that, yes, this is something that's required. Hope to meet you soon. Hope to meet you in your campus, spreading the word about prevention, management, and long-term follow-up of preeclampsia, making sure that lesser and lesser women and their children had to go through this problem called preeclampsia. Now, a big word of thanks to the management and the associates from our SHIELD platform. First of all, for making sure that our 6 VLS series happened without any hiccups, making sure that it is available in a platform free of cost for people who are interested in understanding our preeclampsia and reading about it. But more so, I also extend today a big thank you for you, especially Mr. Balaji, the Vice President of SHIELD, Mr. Singade and Prachi, for making sure that this is extended for another 1 more year. Thank you for recognizing the efforts that goes into it. Thank you for recognizing the need for programs like this. And thank you for being a support for us in our endeavor towards preeclampsia, if possible, eradication from India and from the world. Thank you, Chitrakala and Sahitya Priya, for being the backbone for the dissemination of knowledge about our program, and also for smoothly organizing the day-to-day work of Penai. Thank you so much, the Mirror Health Office staff. Every time it's a pleasure to have worked with you, who makes my life a little more, not a little more, a little too much more helpful and easy, because you know what to do, when to do, and you're so quick at giving back suggestions, feedbacks, and getting back to people with contact. Thank you so much for joining us today, to all the delegates who have been an interesting participation from VLS series 1 to 6 now, hoping that you all will go through these programs that we bring in the future also. Thank you so much, everyone.